Double Jenny. Mia Sabut Takuji Kawamura. Today, I would like to talk about colorectal cancer screening and the way of doing colonoscopy in Japan. So, first of all, I would like to, I really appreciate visiting me. So this is a picture of the 2013, 4 years ago. That was my first visit in Moscow, in Russia. And thank you very much inviting me again in this beautiful city, Sochi in Russia. Thank you very much. And today's contents are the CRC screening and the way of doing colonoscopy in Japan. The way of doing colonoscopy consists of insertion technique and withdrawal technique and management of small polyps. The first topic is CRC screening in Japan. This slide shows worldwide variation in colorectal cancer incidence. In Japan, incidence of CRC is high, same as Western countries. Also in Russia, incidence is relatively high. Colorectal cancer is increasing in Japan, whereas gastric cancer is dramatically decreased. And unfortunately, colorectal cancer is now the leading cause of cancer mortality among women and the third leading cause of cancer mortality among men. Japanese colorectal cancer screening program is FIT-based program since 1992. The FIT means fecal immunochemistry chemical test. So this slide shows the screening program. The program consists of annual 2-day FIT for participants over 40 years old. When FIT is positive, colonoscopy is recommended, and if adenomatous lesion or cancerous lesion was detected, the appropriate treatment and follow-up colonoscopy is recommended. And when no abnormality is detected, the annual FIT is recommended again. In this program, approximately 7% participant is pointed out FIT positives. Among FIT positives, the approximately 4 to 6% colorectal cancer is detected. And the rate of early cancer is over 60%. This slide shows the problem of the program. Yeah, first, the low screening rate. About 30 or 40% of the population is on screening. And second, the low rate of follow-up colonoscopy. Approximately only 70% of HIT positives is performed colonoscopy. And third, no definite guideline after polypectomy. This slide shows the incidence and mortality of colorectal cancer and the screening rates in United States. As colorectal cancer screening rate increases, the incidence and mortality are decreasing. In United States, most of the participants are screened by colonoscopy. I think the screening using colonoscopy must be effective. Recently, randomized controlled trial is ongoing between colonoscopy plus annual FIT versus annual FIT in Japan. Unfortunately, I don't know detail about this study. However, I believe colonoscopy will be used CRC screening in near future in Japan. As I mentioned before, one of the problems of the screening program is no definite guideline after polypectomy in Japan. This slide shows the EU guideline after polypectomy. So patients with low-risk adenoma, such as 1 to 2 adenomas less than 10 millimeters, the patient is recommended to go back routine screening program. And patient with intermediate risk adenoma, the patient is recommended by 3-year interval of colonoscopy. And the patient with high-risk adenoma, the patient is recommended within 1-year interval of colonoscopy. And this slide shows guideline in United States. Also in United States, the recommended interval is also based on the risk of the initial colonoscopy. Also in Japan, there is a simple guideline for management of colorectal polyps published in 2015. This slide shows Japanese statement. The follow-up colonoscopy should be performed within 3 years after polypectomy. However, the problem is this statement is not based on no-risk classification. Now, recently, the results of Japan polyp study is reported. The patients are divided into two groups. The one now is total colonoscopy 1 and 3 years, and the other is total colonoscopy 3 years after polypectomy. The rate of detected advanced adenoma was almost the same between two groups. This slide shows the relationship between frequency of surveillance colonoscopy and advanced neoplasia detection rate. When the colonoscopy intervention is performed twice or more over the previous 5 years, advanced neoplasia detection rate was significantly low, especially in the low-risk patient. Based on these results, new Japanese guideline is under construction. So next, I would like to talk about the way of doing colonoscopy in Japan. As you know, the most important point of insertion is how to pass through the sigmoid colon. The basic technique on the sigmoid colon is do not push and insert to the lower right. When you use this technique go to the lower right, the shape of the scope is like the right side figure. The advantage of this technique for patient is to be painless during insertion. So when the scope goes up and pushed, the shape of the scope would be the gamma loop pattern. So this is gamma loop, and this is the push and right turn shortening method. This is a figure of push and right turn shortening method. When the tip of the scope is reached in the descending colon, and the right turn and the shortening. This is my teacher of colonoscopy. He used the push and right turn shortening method. So now the scope is in the orifice of the sigmoid colon, and he pushed into the upper side of the colon. And the push into the sigmoid colon. And now the tip of the scope is in the orifice of the descending colon. And he uses the right turn and the shortening method.
このスコープは PCF ですから柔らかめのスコープですね。細くてやや柔らかいという感じがあります。で、ただそれにしてもあまり伸びないように、こう引き操作をある程度加えながらスコープをこう入れていくんですね。で、今そうですね。
And now the tip of the scope is in the descending colon.
ほとんどこう SD をこういう時に今伸びてないわけですね。
And however, this method is slightly difficult for beginner to be shortening and often painful. So I use the don't push and to the lower right technique. So this is my plan, the change of position during insertion and manual compression. So I usually use when I pass through the sigmoid colon, the face-up position. And to prevent stretching the sigmoid colon, I use the manual compression. This is my procedure. So here the tip of the scope is in rectum, and now the tip of the scope is in the sigmoid orifice of the sigmoid colon. And if the scope is pushed and the upside, the scope, the shape of the scope must be the loop formation. So then I use a face-up position. And I try to insert into the right, lower right direction. However, I cannot insert the lower right, even the face-up position, and I asked the assistant to compress the abdomen. And then the scope is inserted into the lower right direction. And in the next lumen, the scope is also inserted into the lower right direction. And the next lumen also the lower right and lower right. And now the tip of the scope is in the descending colon with a loop formation. So the next is a withdrawal technique. The routine observation is the point is change the position and retroflexion technique. The change position technique is make it possible to observe the clear image. This slide shows the change of position. That if we observe the right-sided colon, the left side up, left side down, and left side. If we observe the left side colon, the right side down. And the retroflexion technique makes it possible to observe the behind the fold. So retroflexion technique, I usually use in the rectum and if possible, in the ascending colon. So this is my routine observation. So I usually insert the terminal ileum first. And then this is the ascending colon, but some amount of the liquid in the ascending colon. And next, I try to use the retroflexion technique. So, and change the position. The change the position make it possible to move the liquid and air, and clear image can be obtained. Okay. So at last, finally, my topic is management of small polyps. So this is a clinical question in Japanese guideline. How should diminutive adenomas that were less than 5 millimeters in size be managed? So this is a statement. The diminutive polypoid region should be followed up because to decrease unnecessary risks for healthy individual and lower overall cost. Endoscopic resection should not be performed for all diminutive colorectal regions less than 5 millimeters. So, however, recently, cold smear polypectomy technique is widely used even in Japan. So, cold smear polypectomy is easy and low cost and safe. And this slide shows ESGV guideline in 2017. So as for diminutive polyps less than 5 millimeters, cold smear polypectomy is recommended. As for small polyps, 6 to 9 millimeters, cold smear polypectomy is also suggested. However, the evidence comparing efficacy with hot smear polypectomy is lacking. So recently, we conducted multi-center randomized controlled trial named Crescent Study. In this study, we compared the resection rate for cold smear polypectomy and hot smear polypectomy for 4 to 9 millimeter colorectal polyps. So the aim of this study was to compare the resection rate of cold smear polypectomy versus hot smear polypectomy for 4 to 9 millimeter adenomatous polyps. The primary endpoint is complete resection rate. The design of this study was multi-center, prospective, randomized control, non-inferiority trial. This study was conducted among 12 institutions in Kansai area in Japan. And this slide shows the study procedure. The polypectomy was performed using a 10 millimeter sized smear, and submucosal injection was allowed in hot smear polypectomy group, but not in cold smear polypectomy group. The two biopsy specimens from the both sides of the defect after polypectomy to confirm the complete resection. So this slide shows primary endpoint of this study. The complete resection of cold snap polypectomy group is the 98%, whereas the complete resection rate of the hot snap polypectomy is the 1970%. So risk difference was the 0.8%, and 90% confidence interval was between the -1 to 0% and 2 to 7%. So we said the non-inferiority margin was the -3.4%. Therefore, the non-inferiority of the cold snap polypectomy is proved. So this slide shows the conclusion of this study. As for 4 to 9 millimeter adenomatous polyps, cold snap polypectomy is not inferior to the hot snap polypectomy as for complete resection rate. Unfortunately, this study was accepted as original article by GAD, the official journal of British Society of Gastroenterology. And to tell the truth, just 3 days ago, this article was published online, so please check the website. So this slide shows traditional management of small polyps in Japan. The diminutive polyps less than 5 millimeters should be followed up, and as for small polyps, 6 to 9 millimeters is performed by EMR. So based on this recent results of recent study, and I would like to recommend the both diminutive polyps and the small polyps is removed by cold snap polypectomy. I hope removal of small colorectal polyps contributes to prevent future colorectal cancer. This is the last slide of my presentation. So CRC is increasing in Japan, and for painless insertion of colonoscopy, change the position and manual compression are useful. And cold snap polypectomy is not inferior to hot snap polypectomy for complete resection of 4 to 9 millimeter polyps. Thank you for your attention.
Thank you very much, Kawamura-sensei.